Welcome to the Deep Dive. Today we're tackling a subject that really is central to all our lives, cardiovascular health. But maybe not in the way you usually think about it. We're not just talking diets and exercise today.
No, exactly. We're going, well, deeper into how society, how our culture actually impacts our risk of heart disease.
Right. And we're focusing specifically on the UK and Hungary, using an academic poster as our guide.
That's the plan. Our mission, if you like, is to pull out the really crucial bits from this poster, understand how these social and cultural threads weave together when it comes to heart health.
Okay, let's get straight into it then, starting with the UK. There's this term, social determinants of health. Sounds a bit academic, maybe?
It can do, yeah, but it's actually quite simple. It just means all those non-medical things that affect our health.
Like where you happen to live or your education.
Exactly. Where you live, your schooling, your job, your income, all that stuff. It's not just background noise. It actively shapes your health prospects.
And the poster points out this social gradient. What's that about?
Right. So the good news is the UK has reduced preventable deaths from cardiovascular disease, CVD. That's positive.
Okay.
But, and this is the key thing, those improvements haven't been shared equally. There's a clear pattern, a gradient.
Yeah.
Meaning people in, let's say, lower socioeconomic positions generally face more heart health challenges. It's not spread evenly at all. It points away from just individual choices being the whole story.
Got it. So the poster highlights three big ones in the UK. First up, education.
Yes. And intuitively you might think, okay, more education, maybe better health. But the evidence is quite strong.
How strong?
Well, the poster mentions a specific type of study, Mendelian randomization. It's a clever method using genetics to look at cause and effect.
Okay.
And it suggests that getting more education actually causes a lower risk of coronary heart disease. Significantly lower, like roughly 25% lower risk for an extra 3.6 years of education.
Wow, that's quite a drop. Why, though? What's the connection?
Well, think about it. More education often means, better job prospects, potentially less financial stress, maybe healthier working conditions, too.
Right, and maybe understanding health advice better.
Precisely. Better health literacy. Knowing how to navigate health information, make informed choices. And then there are cultural factors too, like community values around education, the resources available. That all feeds into who gets access and how much it helps.
So it's not just the diploma, it's the whole package of skills and opportunities it brings. Okay, the second factor mentioned is employment.
And it's not just about having a job, but the nature of that job.
Like stress levels.
Yeah.
Long hours.
That's a big part of it. The poster cites a study looking at shift work. And the results are, well, they're quite concerning.
Oh.
People working irregular hours seem to have a significantly higher risk of cardiovascular problems, both non-fatal events and, sadly, fatal ones compared to people on standard schedules.
Right, that makes sense. It disrupts your body clock, sleep.
Absolutely. And interestingly, the poster notes this risk seems even more pronounced for women and also for people in jobs that aren't physically demanding.
Huh.
Why less physically demanding jobs?
That's a good question. Perhaps it relates to other stressors or sedentary time involved, but it shows it's complex. And think about our work culture, the pressure, the always-on expectations.
Yeah.
Those cultural norms around work can directly feed into these health differences.
A really crucial point. Okay, and the third big determinant, income.
Yes, and poverty, unfortunately, is a major driver here. The Office for National Statistics data mentioned is pretty stark.
How so?
It shows a really significant chunk of people in England who already have cardiovascular or respiratory conditions are living in poverty, especially in more deprived areas.
And the link is?
Well, it's pretty direct, isn't it? If you're
Yeah.
struggling financially, affording healthy food consistently, keeping your home warm enough, paying for prescriptions or transport to appointments, it all becomes incredibly difficult.
Yeah, basic necessities become luxuries. Exactly. And again, cultural factors can play a part here too, affecting access to financial support, social safety nets for some groups, making it even harder.
Okay, so those are some powerful social factors at play in the UK. Now, the deep dive also looks at how the UK and Hungary are actually trying to do something about CVD through different interventions.
Right. But before we get into the specific programs, there's this underlying concept that's really important. Cultural competency in healthcare.
Cultural competency, what does that mean in practice?
It means healthcare professionals really needing the skills and awareness to interact effectively and respectfully with people from all sorts of backgrounds.
So not just treating everyone the same.
Not quite, no. It's about understanding and considering their values, their beliefs, maybe their language, their socioeconomic situation, all of that. The poster mentions the Pernal model as one way to think about these different cultural
Why
aspects.
is that so important for CVD?
Well, think about advice on diet or exercise or taking medication. What's considered normal or achievable varies hugely between cultures, or how decisions are made as an individual or is the family heavily involved. Effective care has to acknowledge that.
Okay, that makes sense. So thinking about the UK first, there's the NHS health check. What's the story there?
So the idea behind the NHS health check is great. It aims to spot CVD risks early in adults aged 40 to 74. Regular checks, ideally every 5 years, looking at blood pressure, cholesterol, etc.
Proactive stuff.
Exactly. And it's supposed to consider the person's wider situation, their socio-ecological circumstances.
I sense a butt coming.
Well, the concerning thing highlighted in the poster is that uptake, the number of people actually going for these checks, has been falling in recent years.
Really? Why would that be?
That's the big question. Is it about access? Is it communication? Are there cultural barriers stopping people? Maybe a lack of trust? Or perhaps the information isn't getting through in a way that resonates across different communities? Language barriers.
So the system might be missing the very people it needs to reach most.
That's the worry, yes. Now let's switch over to Hungary. They have the 3 Generations for Health program. What's their approach?
This one sounds interesting. Launched in 2019, it focuses on screening across different age groups, like the UK check, but also emphasizes providing person-centered care, tailoring it.
Okay, sounds promising. How's it working out?
Well, the evaluation data mentioned on the poster shows some significant challenges.
Such as?
For instance, getting patients who are at very high risk to reach the target level for their LDL cholesterol, the bad cholesterol. They're apparently doing worse than the European average on that.
Okay.
And they've also had low success in helping people achieve a healthy waist circumference, another key risk factor.
So even with a focus on person-centered care, they're hitting roadblocks. Why might that be?
This is where those cultural factors might come back in, potentially. Things like cultural norms around food, physical activity levels, maybe even how people view illness or interact with doctors.
Right. Patient engagement, health behaviors, they're all deeply influenced by culture.
It seems like both countries, UK and Hungary, are finding it tough. Different approaches, but similar struggles in getting risk factors under control across the board.
Definitely. The falling uptake in the UK and the difficulties meeting targets in Hungary. It really does underscore how these cultural layers can significantly impact how effective healthcare programs are.
It suggests just having a program isn't enough. You need something more nuanced.
Exactly. It points towards needing more culturally relevant strategies in both places, really, to make these efforts work better for everyone.
Which leads us nicely into another area highlighted, particularly in the UK context, social prescribing. What is that exactly?
Social prescribing is gaining a lot of traction, and it's based on that recognition we talked about that health isn't just about pills and procedures.
Right, the social determinants.
Precisely. So social prescribing connects people to non-medical support within their community, things that can improve their overall well-being.
Like what sort of things?
Oh, it could be anything from joining a walking group or an art class to getting debt advice, housing support, maybe joining a bereavement group or volunteering. It's linking people to resources that address those wider social needs impacting their health.
And the poster had that example from St. Bart's Hospital.
Yeah, a really striking one. A significant number of heart attack patients mentioned having financial worries.
After a heart attack, wow.
Yes. And through social prescribing, they were connected to community support for those financial issues. It shows that direct link social problems impacting serious health events and a potential way to intervene.
But going back to our earlier point, for social prescribing to actually work for diverse populations, that cultural competency must be absolutely vital.
Paramount. You can't just refer someone to, say, a generic community group without understanding their background, their language, their cultural context, what feels safe or relevant to them.
The person making the referral, the link worker, needs those skills.
Absolutely. Building trust, understanding the specific challenges someone faces, knowing what support is actually appropriate and accessible for that individual, that requires real cultural competence.
So how do you build that competence in a social prescribing team? The poster laid out some steps, didn't it?
It did, quite practically. First off, actively recruiting a diverse team that reflects the community being served. That's fundamental.
Makes sense. What else?
Regular, mandatory training. Not just a one-off tick box, but ongoing training on cultural awareness, cultural humility, recognizing you don't know everything, and understanding specific cultural practices, communication styles, health beliefs, and crucially, tackling potential biases.
Okay, training is key.
Then practical things like easy access to professional interpreters, not relying on family members.
Essential.
Developing and using health information that's culturally relevant, available in different languages, different formats too, maybe visual aids or audio.
Right, not just leaflets in English.
Exactly. And building strong partnerships with community groups, faith leaders, local organizations. They have invaluable insights and can help build trust.
Tapping into existing community structures.
Yes. Plus, providing good supervision and mentoring for the link workers, specifically focused on culturally sensitive practice, a space for reflection.
And checking if it's actually working.
Definitely. Ongoing review, getting feedback from the people using the service, looking at outcomes, analyzing if the team's approach is culturally competent in practice. It's a continuous improvement cycle.
That sounds like a really thorough roadmap for making social prescribing truly equitable.
It is. And by embedding these kinds of strategies, social prescribing services can be much better placed to genuinely address those social determinants and start closing some of those health inequality gaps we see.
So wrapping this up, the big picture is pretty clear. Social factors, cultural factors.
Yeah.
They're not minor details. They're fundamentally shaping cardiovascular health in places like the UK and Hungary.
Absolutely undeniable. We see progress in the UK on overall death rates, but those deep social divides persist.
And the intervention programs, whether it's the UK's health checks or Hungary's 3 Generations program, their success seems really intertwined with how well they navigate cultural nuances.
Their effectiveness, or lack thereof in some areas, really highlights that influence.
So the takeaway seems to be that really prioritizing things like social prescribing and building genuine cultural competency right into the healthcare system, that's not just nice to have, it's essential.
It's essential if we want fairer and more effective ways to prevent and manage heart disease, ways that actually meet the needs of everyone in our diverse communities.
A really important point.
Okay.
And it leaves you thinking, doesn't it? How might these forces, the social environment, the cultural background, be playing out in your own community, maybe even affecting your own health or the health of people you know? Something to mull over. Thanks for taking this deep dive with us.